All right. Good afternoon, everyone. Let us do this. Thank you for, I don't know if you can hear me. If you can't hear me, just let me know. Thank you for attending another Florida Medical Director Association, the Florida Society for Post-Acute Long-Term Care Journal Club. Today, we're going to really review where we're at with COVID and discuss some of the challenges, which I titled as headwinds that we're seeing as we are continue in this pandemic. So I want to just start here with where we're at as far as our state of the state. I think we are all aware of the surging cases that we're seeing. It is not a surprise to anyone, anything that we are dealing with or experiencing. And I think that as we look at what's happening globally, we're seeing countries that were reported as being under control now seeing the same surges, lockdowns being reinstated in certain countries as well as in the United States. And we are in I think one position I saw on some news media channel said it feels like we're back where we started at, if not worse. So I want to look at that a little and just see where we're at within the United States. And we're over 13.7 million cases. This number is a little different on the Worldometer. It's reporting a little bit higher. And when we look at global deaths, we're seeing that we are over 270,000 deaths in the United States. So we have seen an increase in numbers tremendously in California, in throughout the Midwest, in Florida, everywhere. You know, we're seeing cases, and it is quite alarming when I look at the Johns Hopkins site, you know, to see that 44 states have higher than recommended positivity. I just started debating with myself on whether to even include this as a slide because we're nowhere near where we were even 2 weeks ago when we last talked, and we all I think are feeling the same thing, especially coming down off of the recent holiday. So when we look at Florida's situation, currently we have data through the 30th, and we saw that we had last week we had a sharp increase in the number of cases to one day reporting of over 10,000 cases. On Monday, another 8,600 cases were reported, and the positivity rate as of the 30th was 8.69%. When we look at, if we go back and talk about the slide where we saw on Johns Hopkins data, where that was a 7-day rolling trend, Florida was reporting at 7.69% for a 7-day average, and the United States as a whole is 10.92% for positivity rates. What that means for our state is that we're over 1 million cases now. We are still seeing higher numbers in the South Florida area. Our state has not changed any of the guidance as far as reopening of businesses or nursing facilities. So we're still the same as we were 2 weeks ago. I think that the more alarming thing was seeing so many people walking the streets this past weekend without masks. That's almost as if we thought that the pandemic was over, and now seeing these sharp climbs is very alarming. When we look at the trend, though, within our population and the long-term care populations, we do see better positivity rates among the both the residents and the staff. So, you know, that is really helpful given the fact that we know how detrimental this could be to our population. So looking at the headwinds, there's a lot of challenges, a lot of considerations that we need to speak to as we are moving through this pandemic. I think our last call when we were discussing how to prepare for the vaccination, we had a lot of good insight on what was happening and in real time updates about where we're at. So, I was looking through a lot of the questions that we received into our either through our executive director or directly to me through our innovation task force. We receive a lot of questions, a lot of comments, and a lot of queries. And I wanted to talk to some of these. So, there are some approved treatments that we saw that the FDA has put out, for emergency authorization use. There's a lot of questions about vaccination distribution, preparedness, confidence, and the long-term care pharmacy roles in vaccine administration. We recently had a question about seeing rising COVID numbers with decreased mortality that I want to speak to. And the trendy topic, long COVID, something that you may have seen in one of the many newspapers or on any media cable news channel. And then something that I keep asking myself every single day is, how do we prepare? How do we continue to prepare? And what is the future state of post-acute long-term care? So when we're looking, the new treatments that I don't think we've spoken to yet on this call about are monoclonal antibodies. And November 21st, oh gosh, what day was that? Maybe a Saturday or something, we saw that the FDA authorized monoclonal antibodies for treatment of COVID-19. Now, when we're, saying that, we received a lot of questions from both the Florida Healthcare Association, ACA. I think there was a question even from the Department of Health about what is our position? What are our thoughts about using monoclonal antibodies in the nursing facility? And it's a great question, and it's an interesting thought because, with the first trial that came out where this was presented to the FDA issued the emergency authorization. It was called the Blaze-1 trial. And it was randomized, double-blind, placebo-controlled study in which they looked at individuals with mild to moderate disease in the outpatient setting. So there was no long-term care residents being studied in this phase of this trial. Lilly is doing another study, and which we'll talk about in a minute. But as we were seeing these things in anticipation, I would say that AMDA put together a very detailed letter that I believe is in our library, and if not, we'll put it there, where they addressed to the Department of Health and Human Services the importance of doing clinical trials in our clinical setting. If you don't know, monoclonal antibodies, I think we've seen literature about this over the past month as a possible emerging treatment, and we have had favorable findings in the clinical trial for mild to moderate conditions in the outpatient setting. We do know that the President of the United States had a treatment similar. Well, I think it was renamed. He had Regeneron, but it's been since rebranded or given the generic names is what was actually authorized. So we do know that this has been very popular. I applauded what AMDA did because, we saw some detrimental issues when we implemented compassionate care with certain medications in the beginning of this pandemic. So pushing back and making sure AMDA took a position stating that we need more research. This is an IV and IV infusion. How would we even begin to do this in the nursing facility? I thought that was an excellent point that they made and sent this letter out to the Department of Health and Human Services. What we do know is that Lilly is conducting a second trial, Blaze 2 study, where they have invited long-term care facilities to participate. And I believe it's still open. So if there are facilities who still want to become a part of this, they can become a part of this trial and look at how do we utilize these treatments in the nursing facility at the facility for our residents. So there is more to come. We're going to get more information about this. The study doesn't conclude until the spring, and we're not even anticipating any results until June. So June of 2021. So there is a lot that needs to happen, and there's a lot of things that we need to know. But I think that when we're looking at the ethical challenges that we faced with medications in the beginning of this pandemic, it is really nice to see that we're actually doing some research on this in our population. Wanted to also revisit vaccine preparedness. There has been a lot of questions, and I think we received one question from a long-term care pharmacy consultant just the past few days, speaking and questioning why Health and Human Services signed a deal with CVS and Walgreens to distribute COVID-19 vaccines to nursing facilities. And our speaker 2 weeks ago spoke to this, but just to make us all aware, there are so many requirements and so many issues when it comes to how to deliver this vaccine. There's cold storage that is needed that is beyond the capacity of many of our facilities. And, I think there's a lot of things that our long-term care pharmacy consulted groups could do, but there may be some challenges. And so I think that was the consideration that went into partnering with pharmacies like CVS and Walgreens, who both have long-term care arms. And I appreciate all of the work that Omnicare has helped us with their part of CVS and all of those, the questions that filtering all of those questions that have come in to us. The main issue that I see is in how they establish and what they're going to do. So we were informed by Rick Foley that CVS may go in room to room and administer the vaccine, whereas Walgreens set out some information around setting up clinics within the facility. And I do see that as something that we really need to partner as clinicians and clinical providers in the facility, medical directors of these facilities. We need to really partner with our long-term care pharmacy consultants to make sure we are following the infection control guidance that we have laid out and work with those pharmacies, such as Walgreens, if they're setting up that clinic. Now, not every facility had to sign into this pharmacy partnership. So and I don't know of any offhand. I believe I'm going to try to put a survey together just to get a sense of what is happening out in Florida. But there are some facilities who did not have to sign into this partnership agreement and can work with their long-term care pharmacies to do make another plan. And there's information that Health and Human Services has on how the pharmacies can work with their departments of health and outreaches that you could do so that you could get coordinated. There are also, when we're looking at partnerships within the community at large, there are several grocery chain pharmacies that have been approved to distribute the vaccine. There are other pharmacy groups that are able to distribute the vaccine. So while the part of the whole partnership where you were able to say, I want to do this, may be closed off, there are still other avenues and other ways to, if your long-term care pharmacy consultant group wants to distribute the vaccine in a different way, and the facility has agreed to do that. As far as what we see as a plan, this is what the CDC produced back in September, of having a phased approach. And looking at the way Florida has interpreted this, we saw that if the Florida's approach, long-term care hospital and long-term care residents were in that first phase, I think there was a little bit of a difference in the way the CDC was initially reporting it. But as of yesterday, there was a 13-1 vote. And when I heard this, I was like, who was that one person who was voting against prioritizing nursing home residents? But, we will see prioritization of nursing home residents and healthcare workers for COVID vaccine throughout the country, which is amazing news. There are even more opinions and editorials that came out just really applauding the fact that we're going to prioritize nursing home residents in the news that came out today. So I thought this was a really great thing, and I wanted to just highlight that, because that will definitely help us in fighting this pandemic. The other thing that, just to keep everyone up to date, is that the UK became the first country to approve Pfizer's COVID vaccine. The EU is, I think, was alarmed and pushing back on what the UK did. But, it is really encouraging that we're seeing this. I do hope that as we're doing our assessment of the vaccination and making the vote to see what we're going to approve it, that we do follow the guidance. And I think when it comes to looking at the way Pfizer and Moderna and even AstraZeneca have been moving through this rapid phase of and trials, there's a lot of good science behind it. So I'm very hopeful. So I believe the meetings that the FDA is going to have on approving Pfizer will occur on December 10th, and the one for Moderna, December 17th. And if I believe that was the latest that I've heard. So if anyone has heard anything different, I would encourage you to please share it, because I think it makes us hopeful that we may be able to see a rollout of the vaccination before the end of the year here in the United States. So another question that keeps hitting us, and that I think has proved to be a little bit of a challenge, because the way the public, the way our caregivers and patients may be viewing this, is that we do see that mortality is decreasing as cases are rising. So we have one question that came in through AMDA's forum about that. And I think it also hit FMDA's inbox about why are we seeing this and what could be happening. So we've been looking at this, and this is from the Journal of Hospital Medicine, where they were looking at the trends back in August to September of what they were seeing as they saw decreased mortality, despite the fact that we were still seeing increases in cases. So what they were really focusing in on is the fact that they saw more younger people with less comorbidities contracting COVID, and that was adding to the fact that we were seeing decreases in mortality rate. I think it's probably a bit multifactorial when we look at the data, and this is from Johns Hopkins, of where we're at. The United States mortality rate is 2.2%. So one of the most important things to think, there is a difference in the demographics that we're seeing. So we are seeing a younger population. The question has been raised, are we treating this better? And I would probably think that we're identifying it earlier. We now have more testing available, even though some areas still are lacking, and there is probably a case to be made to have even more testing available on the throughout our communities. We are doing state to state. We're doing more testing, so we are identifying cases. We are identifying them earlier, and we have learned a lot about how to treat this disease. So not everyone is being intubated. We're using CPAPs in the hospital a lot more often. I think we've found ways to identify, even in our nursing facilities, to treat them in place. And it's definitely having an impact. But I think the biggest thing is that the fact that we are testing more of the population. So we are finding more cases and identifying more people who may have mild to moderate disease. The unfortunate thing is, though, when our residents do contract this, we do see within our facilities higher mortality rates. So this is a look back over the past several months of what was happening. And it is to note that not all states were reporting their nursing facility deaths, but when we look at residents and staff, it was over 100,003 residents and staff members who have died in the past few months from COVID. This takes, as of November, we're getting reporting from every state except for Alaska, and the 50th is the District of Columbia. So we're getting information from most of our areas about what's happening in our nursing facilities. And this just came over last week about the impact that we're seeing in the facilities, which is something that I know we are all aware of because we're living it. When we wanted to just hit on and touch a little on long COVID, like I said, this is something that you'll see in the news media a lot. It is, as we're seeing stories unfold, I think I've seen stories in every major paper and on every media channel. It is interesting because we're now doing more studies on it. There's guidance from the Mayo Clinic for their patients. I saw something on the CDC where they're speaking about it as well. So this study's from the Clinical Microbiology and Infection Journal, and they looked at those adults who had non-critical COVID, so the mild and moderate cases, and looked at how long they had symptoms. And this really took a 2-month look back. And they found that after 2 months, they still saw that there was, and looking at 150 patients, they still saw that there was a high report of people having loss of taste and loss of smell being two of the more common issues. There also was shortness of breath reported, and I think the most common was cough. When we look at some other studies, and this is a study where they looked at the COVID symptom study app that they had published, and this looked at 4,812 users and how they reported their symptoms improving or persisting over a certain amount of time. So they found that 558 people reported that they had symptoms 28 days after, being cleared, and about 200 people reported that they still had symptoms 8 weeks later, and a little less than 100 people reported they had symptoms 12 weeks later. The bigger thing that was found in this study was that the people who were reporting the persistence of symptoms were most likely older. And when they looked at the age demographic, they found that there was 22.8% chance of likelihood of people over 70 having prolonged symptoms. So it's something that I think we are in position to research and to really get a sense of. And I know we had a conversation about this with Dr. Healy and I believe, back in June. But it is interesting that this is still something that we still need to see more data on. And I'm surprised that we haven't seen more information come out in the Journal of American Geriatric Society, or a JAMDA. So I'm hopeful that somebody within our sphere is studying this. The thing that I do think that we need to continue to talk about is not just the long COVID symptoms, but the impact of COVID the impact that COVID has been having on our residents, whether they were positive or negative. And this study that came out last week at JAMDA is very interesting. They looked at 209 residents, and some of them were positive for COVID, and the rest of the population was negative. What they found is globally, everyone was losing weight, and it was secondary to the social isolations and the visitation restrictions, and is what they thought was probably the predominant factors when they looked at the whole population. And it's something that I think we've had discussions on when we were thinking about the reopening and visitation guidance for our facilities that we spoke to. They saw, though, that those people who were COVID positive had a larger percentage of weight loss and absolute weight loss. So there is a difference between the populations, but the fact that we saw anorexia in both populations may speak to the lack of socialization that we were seeing in our facilities, and still continue to see in the facilities, secondary to the restrictions that had to be put in place. I want to hit on, before we open it up for discussion, just some things about infrastructure and where do we go from here. And, I don't know if anyone is paying attention to the fact that we've seen nursing home workers go on strike in several states. This is an article that I picked up from one paper in Chicago, where nearly 700 workers were on strike. And I actually was able to see their press conference they had this past weekend. And they were asking for things that I think we're all aware of, like hazard pay. The fact that they're working more hours, working longer hours, having to cover people, having to come in and work when the facility is short of staff. I think that's been significant, and that is something that many of our facilities and our chains are talking to and thinking about. The thing that I thought was very interesting, though, is that one of the workers was stating something that I think we're all very aware of, but I don't know how aware the public is. The fact that we are still seeing shortages of PPE in several of our facilities. Within Florida, we see this, but across the country, there are still a lot of issues with getting supplies. And some facilities, you're asked to bring in your own stuff, as practitioners in that facility, as the physicians and nurse practitioners and physician assistants, as we're going into those facilities, we are aware that we may have to bring in our own PPE. But I thought it was interesting to hear several CNAs speak to the fact that they have a lack of everything, and they are being challenged because it's making it very difficult to provide care to the residents. Something that I thought was really interesting and good, and I think we have it on our in our library, is the pandemic playbook that Leading Age put out. It is several chapters long, and in it there is they pull from a lot of different resources, some that we've spoken to, some that AMDA and American Geriatric Society has spoken to, where you can look at different things, go through videos, and they really speak about how we need to evolve our risk management, our ongoing preparedness, and strategize for future outbreaks, epidemics, and pandemics. So if you are, I think as we're trying to figure out where do we go from here, this is a good starting point. I know that several states have playbooks out there, and different departments of health task forces have developed them. I think that, it's a question that we're not going to answer like in 5 minutes, but it is probably the one thing that keeps me up, trying to figure out how do we do and get better at doing this, and what things we need to keep our facilities moving forward. So with that, I'm going to open it up for discussion. And hopefully you guys, I can't see the chat shade. So if there are questions, I don't know if anything came through.
Yeah, so we do have a couple things in the chat. From Elaine Healy, we have, what is missing is information on the incidence of deaths in nursing homes. Good to know the cumulative numbers, but are nursing home residents still dying at the same rate as they did in the early months?
Yeah, that is interesting. And I'm not sure. I haven't seen that information broken down like that. I will say that what we have seen in looking at some public health data is that some of the increases that we've seen, other factors related to people dying in not only in nursing facilities, but people with chronic comorbidities passing away because they have not been able to get services or have not been maybe seen by their physician. They're not going into the hospital or utilizing services the way that they were in the past. So that same trend has been seen in some of our facilities due to just the abatement that we saw with in provider visits that we saw in the beginning of the pandemic. Some of that is still persisting. So even though we are seeing more people go to their doctors now, seeing more people either engage in telehealth, I do anticipate that there's going to be some numbers that we're going to be able to look into to see how the trend is with our nursing facilities, because we know that some were not adequately staffed. There were challenges with telehealth. So getting to those residents who had ongoing needs that may have been in isolation from COVID, heart failure, COPD, other conditions. We do know that there's been a increase in death amongst people with comorbidities, even when they did not have COVID. Yeah. And I'm not sure, Elaine, if I answered your question.
Hey, Diane. You did in many respects, but here's what I find it shocking that we're almost a year into this, and we all know that 40% of fatalities from COVID in the U.S. have been in nursing homes, and you would think we would know this information. We would have it at our fingertips. And I question, for example, places that are having what I consider maybe their first real outbreak, states that are really seeing their first wave, whereas we experienced it in the spring, in the early months. Are nursing home residents dying the same way in the same numbers as they did in Kirkland and in New York? Are they dying like that in North Dakota nursing homes right now? And I don't think we know. And I think we should know. On another note, I'll just say that in New York, we're seeing, as in other places, we're seeing an increase in hospitalization rates in our area, and sort of rising up the curve again. But we're not seeing any what I call clinical COVID in the nursing homes. So we're not seeing, although patients may test positive and be called a case, we haven't seen actual clinical disease since May, even though the cases are going up all around us in the neighborhoods, in the community. So I just think, it's something different is happening in this second surge, if it is that we're experiencing. And it's pretty amazing that we really don't have the answers to what I think are pretty fundamental questions. So that, I don't know, maybe if anyone else on the call has some insight, and I'm hoping maybe through AMDA, and there's the state open mic tonight, that we'll hear from some of these states as to what's going on in their nursing homes.
Yeah. I think, I'm looking forward to that too, because I'm very curious to know what we're doing different. I do know that I've spoken to some people both from North Dakota and South Dakota, and there were some changes that were made, and there are some issues getting some of the reporting. Like I said, we're not getting everything uniformly, so we don't know everything that has happened. And as far as the data that we're trying to see on mortality, but I do think it's interesting because I know that one of the medical directors who was once on the task force in, I believe, North Dakota, then was removed after they were saying we need to do this and that, which, is a lot different than what happened in Florida. I mean, they got on the task force in Florida. There's, a lot of things that has not happened. But, I think it's interesting because there's always that political factor. What happens when you disagree with the governor, regardless of what the party is? We've seen that there's been a lot of pushback on our industry when we're trying to give guidance, and I don't know why that is. I think that we have a big opportunity though to really make it known how to do what we're doing, like where it works, and we should be publishing that information. Right. This is where the numbers have gone down with COVID. This is how we kept it out of the facility. This is what we saw as a trend. We should be publishing that like hardcore data, so that we can speak to it. That has been the thing that I've been most disappointed. Like I was hoping that this study was already done. I was hoping that I could find that information out there so that I could have that answer. And when I tell you I looked through like 1,001 things just for fun, I still couldn't find that that study being produced. I think we have someone who raised their hand.
Hi, Diane. Can you hear me?
Yes, I can hear you.
Yeah, this is Terry Hill from Oakland, California, past president of our local AMDA chapter. I have a couple of comments about data. I'm working with our local public health department to try to get really accurate numbers on the cases, hospitalizations, and deaths of residents and staff in long-term care. And my innocent, naive notion months and months ago is, oh, this sounds easy. You just get all the line list that the SNFs submit to the public health department. They've got pretty good. They're pretty good. You've got names of everybody. And then you just match those with the confidential morbidity reports and the death data. Well, it turns out none of that is easy. And the only study I know that has used line lists to get accurate data was from the CDC study of Fulton County, Atlanta, where they used the line list as gold standard. Now, I think that our cases and deaths of residents are probably fairly accurate, but when you think about it, the nursing facility doesn't necessarily know who died, right? So, because they may send the patient to the hospital and may not even hear, and certainly may not report. So we're depending upon somebody checking a box about long-term care on the morbidity reports and the death certificates in order to know whether they're connected to long-term care at all. And I think that's unreliable. I would like to think that the line lists, in fact, are the source of truth, and that it's worth cleaning those up and doing the matches, particularly for the staff. We now know that the staff residency in a high COVID zip code or census tract predicts infections in the facilities where they work. So in order to get to that, we have to do the hard work of cleaning up those line lists. So I just spent 4 days over the Thanksgiving holiday doing long days of cleaning up all that stuff. But so I wonder if anybody else is doing that on the call or has ideas about how to proceed.
Oh, that's very interesting. I might call on Dr. Kaplan because it sounds like something Dr. Kaplan would do. Dr. Kaplan?
Yeah, I'll come off. No, yeah. I'm not aware of that, being done. Certainly in Florida, maybe Ian has some additional information or any information regarding that, but we certainly haven't done it internally. And I'm not aware of the DOH of what kind of stats they have on that as well.
It's interesting. You may have to explore that. Shane and Ian, if you're taking notes, I think that is something that we would want to see how it all is adding up.
Diane, can I add one more tidbit? A lot of our staff are getting their test at pop-up sites, drive-through, et cetera, where the diligence of checking that long-term care box is zip, right? So again, the only way to do this is to start with their name and birth date and then match it back. And the unions have been trying to do some counting of their members' deaths, which I commend, but obviously that's incomplete.
Yeah, I think it's interesting for, like, here in Florida, most of the staff are getting it with when they have to do the testing with the facility. So there is an ability to track it back, and it is something that we can explore with our Department of Health, because I think it's something that we may be able to get a little bit differently, just because of the way the state has regulated that the staff and the residents have to be tested. All right. Any other comments, questions in the chat box, or anyone else?
Diane.
Oh, hi, it's Elaine. I was just going to say that in New York, all the deaths are registered electronically, and they have a place of service field. And of course, the diagnosis, cause of death is indicated. So it really should not be all that hard to figure out how many people have died in nursing homes, the absolute number, and also the cause of death. That data is there. We've requested it, but we haven't received it from the DOH.
Okay.
Diane, on a little bit different topic, but going back to deaths and the incidence and prevalence or incidence of deaths in nursing home over time compared with 10 months ago. I'm wondering, okay, I know it's not been done, but I was thinking it might be of interest. We've seen so many, we've had recurrences. We had a huge incidence, okay, of unfortunately in one of my 3 facilities of deaths in March and April. That particular facility had, I'm going to use the phrase a recurrent outbreak. If you want to use the word outbreak, technically it definitely was. We had 1 staff member and 1 resident turn positive like a couple of months ago. And in 2 of my other facilities, even though we've had 2 or 3 or more staff members, we've had just a smattering of residents that have been positive, maybe 2 at a time, et cetera. And these are totally asymptomatics. all of these people I'm talking about are asymptomatic, so they were just isolated, the usual, precautions, transmission precautions, et cetera, but they stay in house. My question, my wonder with this is that it would be before we started doing all this aggressive testing. I'm saying we date back in nursing homes probably to around August or September. I wonder what the incidence of antibodies in many of our residents was, as far as people who developed COVID asymptomatically between March and June and July that developed antibodies. And that's the reason why we're seeing a lower incidence when we get a recurrent outbreak in our facilities.
That's interesting.
Terry, I see you smiling with that, but I don't know if that.
You have any comments, Terry? Because that is.
No, I think we have to pat ourselves on the back a little bit here in that, yes, in my area, we're getting much smaller outbreaks, the onesies and twosies. And some of that is, hello, we've got PPE now and we're starting to use it and we're washing our hands a little better and we're screening. Someone said we're kind of beginning to master this a little bit. Like influenza every year is a routine, right? You plan, you've got your checklist, you do boop, boop, boop. And now when a recurrence comes to a facility that's already had an outbreak, they go, oh, here's a drill, red, green, yellow, and we're done. So that's, I would love to see the antibody study. But meanwhile, I want to congratulate everyone for learning how to, do the right thing.
Any other comments or thoughts?
I think I just go back to wondering what's happening in states that are seeing their first outbreak. I mean, I like to think that the reason we don't have, and I refer to it as clinical COVID. I really take issue with the case definition, just being a positive test. We've had residents randomly turn positive. No one has developed clinical COVID disease. So I don't know whether that's because we've done something really well. Or if people that are doing the very same things in states that are seeing their first wave of COVID, if they're experiencing what we did back in the spring. That's my question.
Okay. I don't know if I have an answer, but I want to get to Dr. Parvez. I'm not sure if I say your name right. Let me make sure. I think if you're speaking, sir, you are on mute. So. Can you hear it? Elaine, did you have another comment while we're trying to get him?
No, just, wondering what's going to happen with the vaccine and so forth, but we're all in the same boat.
Yeah. All right. Okay. Any other questions or comments?
Oh, maybe you may have addressed this, but the issue of, the lockdowns, the nursing home lockdowns, the isolation and the morbidity and possibly mortality that's resulting from that. I think that's really starting to hit the news now in a way that sort of the way the original nursing home deaths lagged behind everybody's knowledge of what was going on in the hospitals. And maybe we'll see some, real advocacy from the families and others that are just suffering. So as our residents, apropos of what you said in your journal article about the weight loss. So these are, the collateral damage, which is ongoing, and I'm glad it's being publicized. So maybe something will happen around that.
Yeah. And I just think that it's an opportunity for us to maybe write more, do more local, state, and national advocacy so that we can definitely explain what we're seeing and what we're anticipating seeing. I think that is, when I looked at that study, I just saw opportunity for us to do more and to work together to get in front of some of these challenges that we know we will be seeing. Yeah. Now, I know I have only another person who can't get off, let me see, mute, but if you guys have any questions, any comments, any thoughts, I do have the comment from Dr. Perez. So patients may have antibodies at herd immunity in centers who have had initial outbreak. I think that's what, to Dr. Kaplan's point, that we really do need to look at. I know there was a study, or there is a study that is going to be published from regarding some Louisiana nursing homes where they think that herd immunity may have been a factor and why they didn't see larger outbreaks, because there may have been asymptomatic cases that were initially missed. Yeah.
Hello, can you hear me? Hello?
We can hear you now, yes.
Yeah, because, I had a patient in a nursing home who had typical, COVID symptoms. PCR was negative twice and eventually got better. We didn't send her out to the old lady. And later we just did an antibody test like after a month, and it was really positive. But she did have COVID. She had a typical chest X-ray findings. So there could be patients that had some like mild symptoms that were negative or were asymptomatic that we didn't test antibodies. And they're creating a herd immunity in the center. So that's why we're not seeing a second wave. Although we are seeing some patients who are positive after 3 months of being positive first, and most of them are fine. Like there are 1 or 2, 3 patients. Their PCR is positive. We did it for some other reason because the employee was positive, or they went to the hospital and came back for some reason, and they were positive. But most of them are asymptomatic and they've been fine. Just a comment, I don't know if we're seeing that at other places, but they were quarantined because it's been more than 3 months since the first positive test.
Yeah, I think, like I said, I think there's some journal articles we're going to see coming out soon, speaking about just that, like was there herd immunity because there was asymptomatic exposure beforehand, and I think it's a really interesting thing, and the fact that we're seeing new centers in regards to nursing homes, like we saw the issues that North Dakota, South Dakota, some of the other Midwestern states were having, that we didn't see happening on the East Coast, where we had nursing homes hit the hardest in the beginning of this. I think it's all interesting, and we really need to explore that.
Yeah, I'll be looking forward for any research you're doing, looking at the data with antibodies in the nursing home setting.
And just to make a comment, non-Floridians can always join our journal club. It is for everyone. Thank you. I think as we look to where we need to go next, we're going to try to talk about more of the clinical manifestations and what we're seeing in our facilities and what we may be missing, like ways to make the diagnosis even earlier. So in 2 weeks, we will have a presentation on the skin manifestations that we're seeing that are possibly related to COVID. And I hope everyone who's on this call could join us for that. Thank you, everyone.